There I am. Just realised that I am matching my profile picture with my jumper today.
Oh, what, if you hadn't have sent anything, I don't think many people would have noticed.
I like I like to be consistent in my approach.
It's so we can recognise you, that's all.
Yeah, absolutely.
So we'll make a start because it's 20 past. I asked everyone to come back for 20 past. So
Okay.
I'll hand over to you, Nikki. If you can just let me know when you want me to go on to the next slide, please.
Yes, and I will thank you in advance, Chloe, because some of my prompts will be next slide, but a couple of them will be next animation, please, on the same slide. So if you don't mind, I'll do that. That's a bit later on in the session. So good morning, everybody. My name is Nikki, Personalised Care Training Manager for Buckinghamshire, Oxfordshire and Berkshire West Integrated Care Board, and we often refer to ourselves as Bob ICB. And our team had been tasked as part of an NHS England personalised care upskilling programme to train 75,000 healthcare professionals by the year 2023, 2024. So we've been delivering personalised care training across our Bob footprint, and I'm happy to be invited along today to join you. I plan to prime you with a bit of what personalised care is, and include a few more details around some insights, my own inner ramblings, shall we say, because I've learnt so much over these past couple of years and continue to learn, and as well as some case studies. So to start, next slide, please. Just have a think to yourself. What matters to you as an individual for your health and your care? What matters to you in your work? And how would I, or how could I, as a healthcare professional, say and understand what matters to you in your health and care and in your work, in conversation, in processes, and also in partnership? Next slide, please. So, anecdotally, this is what matters to you. So, being or feeling prepared, and preparation is key to a meaningful conversation and promotes movement and progression towards positive and appropriate action. How can we prepare ourselves to deliver good personalised care? And how can we help to prepare patients and their carers and families? And having choice and autonomy with decision making, shared decision making is critical to ensure that consent is valid and that patients are made aware and are able to vocalise their perspective and how them as an individual might consider those evidence-based risks of their treatment in the context of their own lives. Next slide, please. So why does it matter? So we know that the concept of personalised care isn't new, but policy is fairly recent, having been embedded into the 2019 NHS long-term plan. And it matters because we should accept in our healthcare systems that we all have our unique perspective and outlook on life, and we all have different wants and needs. And this is how the same clinical evidence base can lead to different decisions and different results, but ones that hopefully work best for the patient, or should work best for the patient. And today is an opportunity for us to reflect: how do we equip ourselves and our patients to prepare for that path ahead? And how do we share knowledge and information? And do we consider that information to be accessible? And how do we ensure an equal partnership? Next slide, please. And thus, personalised care is based on what matters to people in the context of their world, instead of focusing on what's the matter with them and working with their individual strengths and knowledge to optimise health outcomes and experience. We have it within our power to enable the person to be the best version of themselves, helping them to increase their capability and their opportunity to improve their health and well-being, to make decisions about the treatment and care that's right for them. Next slide, please. And personalised care improves confidence with self-management, thereby decreasing demand for services, reducing avoidable hospital visits and admissions, and primary care appointments. and that personalisation of systems and processes help ensure a more equitable approach to care provision and thereby reducing inequality where patients access services. Slide. So this is a short overview of that policy and guidance. So this is a document called the Universal Personalised Care, and this is an operational handbook which details these 6 evidence-based components of personalised care and explain how personalised care should be rolled out in practice to ensure an all-age, whole population approach to personalised care. And this is used in conjunction with a comprehensive model of personalised care, which I'll show you in a couple of slides' time. Next slide. The policy introduces these 3 relatively new roles. Some of you might already be working in these roles even. So we have social prescribing link workers, and this approach connects people to local activities, groups, peer groups and services to meet their practical, social and emotional needs that affect their health and well-being. And social prescribing link workers give people time, focusing on what matters to the person to co-produce a simple personalised care and support plan to help the person to take control over their health and well-being. And health and wellbeing coaches continue to support people to develop their knowledge and skills and confidence to become active participants in their care. And these coaches support people to increase their ability to self-manage, increase their motivation levels and their commitment to change their lifestyle for the better. And they work with people with physical and or mental health conditions or those at risk from developing them. And then care coordinators work to review people's needs and connect them to services and the support that they require across the health and care system, helping people to make the right connections with the right teams at the right time in the right place. Next slide, please. So this is the comprehensive model of personalised care. Now, I know the writing at the side's a bit small to see, but I can forward a link so that you can access the PDF document, and also it's got a video to explain more. So this establishes a whole population approach utilising those 6 components of personalised care to support people to manage their physical and mental health conditions. So in the whole population, you would expect healthcare workers to work with the person utilising a shared decision-making approach. People might require more connection to their local communities, so that's where the social prescribing link workers can help. If people are living with and managing a long-term condition, they might require a personalised care and support plan. They might need to increase their health literacy levels so that they're better able to do that, and might need some health coaching to support them with self-management techniques. And people with living with more complex healthcare needs, they might need all of the above. So shared decision-making approach, having a care and support plan in place to help them manage and live well with their condition. But they might also require a personal health budget, which is a pot of money that helps the person to bespoke their care to meet their own needs using a personalised care approach. So that's the comprehensive model of personalised care. Next slide, please. So often in our training, we refer to the Cochrane Review from 2015, which focuses on the impact that personalised care approach can have on patients with long-term conditions. So in this systematic review, 19 randomised trials were analysed, utilising the question as to whether those personalised care interventions actually lead to better health outcomes. So they had just under 11,000 participants, people with diabetes, heart failure, kidney disease and asthma were involved in these groups. And the results showed that a personalised care approach led to better physical health, better emotional health, and actually a better capability to self-manage their condition. Next slide. So how can we help to prepare ourselves and patients for good personalised care? Next slide. So we can build and we can continue to build our knowledge and our skills and confidence in these two areas as a starter. So shared decision making and motivational interviewing, which in my view, these two help to improve the working lives of healthcare workers and of course, patients who we support and treat. Next slide, please. And so shared decision making. So shared decision making is when both the healthcare professional and the patient prepare to come together as experts and as equals to listen to one another and share perspectives, to explore options and bring everything together to make a decision about tests, treatment and care. It helps the patient to make informed choices and to provide valid consent. And the earlier conversations allow more time and space to make better quality, safer, and sustainable decisions. It's also a process. Shared decision making is also a process because the conversation aids the decision making, which then leads to the agreement and onward planning of the treatment and care. So that's the process at various decision points along the breadth of the patient's clinical pathway. Next slide, please. And I just want to raise awareness of a couple of pieces of guidance. So we have the General Medical Council that have published 7 main principles to ensure a personalised and safe approach to decision making and consent. And the guidance really focuses on the legalities and the ethics of consent and deciding to consent for decisions relating to treatment, as well as the prevention of harm to patients, and that consent is a fundamental and legal ethical principle. And all patients have the right to be involved about decisions about their treatment and care and to make informed decisions as much as they can, and importantly, as much as they want to. And it provides guidance on what you should tell a patient when talking about risks, what to do if your patient doesn't want to hear the information that you think is relevant, and what to do if the patient might lack capacity to make a decision and what you should record. It's designed primarily for GMC registered staff. However, the principles of involving the patient in conversations about their treatment and care remain the same, as you can see on the slide there. Next slide, please. The other main piece of guidance is from the National Institute for Care and Excellence. You can see that it covers what shared decision making is, what should be included into the shared decision making process, how we can embody this at an organisational level, how we can put it into practice, what decision aids are, and how we might communicate risks, benefits and consequences. And then you can see that the guideline underneath focuses on decision making in the context of mental capacity. So that covers decision making for people aged 16 or over who might lack capacity now or maybe in the future. So it makes recommendations on supporting decision making, advanced care planning, assessing mental capacity to make specific decisions at a particular time, and also best interests decision making. Next slide, please. And all of this is underpinned by this main legislation, so namely the Mental Health Act, which covers the assessment and treatment and rights of people with a mental health disorder. It's undergoing some reforms to further underline and the patient's right to choice and control, because there's recognition that current processes don't enable that as much as it could or should be. The Mental Capacity Act promotes and safeguards decision making within a legal framework for people aged 16 or over in England and Wales. The Human Rights Act, under the European Convention of Human Rights, details the fundamental rights and freedoms of everybody in the UK, the right to life, liberty, freedom of thought, belief and expression. And then we have the Care Act, where independence is the name of the game here. So details how what those health and care service obligations are to enable a person's independence and well-being, which includes support for unpaid carers such as family members and close relatives, and also details around advocacy services for patients should they need it. Next slide, please. So I mentioned a bit earlier as part of that NICE guidance about decision support tools. So in practice, there are available evidence-based decision support tools which are designed to support patients to work through the risks and benefits of a particular treatment with their healthcare and medical professionals. And it's important to consider if the patient has accessed the correct information beforehand. Are they prepared? The healthcare workers or the healthcare professional prepared to have the conversation? This decision support tool helps with that, but that information should be provided in a format or language preferred by the patient, and with the necessary wraparound support. NHS England, there should be some hyperlinks embedded in those logos there to access the decision support tools. However, I can send some follow-up information about that. But NHS England continue to upload new decision support tools all of the time, upload easy read versions of those decision support tools, as well as alternative languages. Next slide, please. So did you know that 1 in 6 adults in England have poor literacy skills? 4 in 10 adults struggle with health content for the public. 6 in 10 adults struggle with health content that includes numbers and statistics. 1 in 10 people in the UK has some degree of dyslexia. And a lot of health content is written often unintentionally for people with higher health literacy skills. And low health literacy has been linked to poorer outcomes and inequality. Next slide, please. And here is a little about motivational interviewing. So motivational interviewing is about working side by side with the patient, both facing towards their path to positive change. It's about arranging conversations to increase motivation so that people talk themselves into change based on their own values and interests. And it's a guiding technique to help an individual to take that step towards change, eliciting self-change through coaching tools. Next slide, please. And the ethos of motivational interviewing allows us to embrace our differences and play to our strengths. And our main goal is to uphold the spirit of those 4 concepts at the bottom, that we accept where the patient positions themselves in that stage of change, that we collaborate with them and avoiding not doing to them, that we have empathy and compassion. So empathy is more of a quality, where compassion takes some skill. Empathy is the capacity to understand or feel what another person is experiencing from their frame of reference. Whereas compassion, on the other hand, is more of a constructive approach. It's more equitable. It starts out with empathy and then turns outwards with that intent to help, turning that emotion into meaningful action. And helping to evoke and empower the patient, helping a person to draw out their good reasons for change. And in motivational interviewing, it really is around holding space for people to think and actively championing a person's inner resourcefulness. Next slide, please. And here are some of those conversation techniques and skills, better known as OARS, which stands for open questions, affirmations, reflective listening or reflections, sometimes referred to as reflections, and summarizing. And affirmations are statements that recognize a person's strengths and acknowledge behaviors that lead in the direction of positive change, no matter how big or small. And they build people's confidence to change. They should be delivered authentically, focused on a certain behaviour, attitude, or skill set the person may have. And this helps to promote learning, performance, raise self-efficacy levels, and a person's confidence levels. Next slide, please. So where might you come across shared decision making and motivational interviewing, or even any of the other personalised care approaches? So here's just a few examples, but there could be so many already happening in your own areas even. So in elective care, or sometimes we call it planned care, if somebody's elected to have surgery, for example, that would involve a shared decision-making approach. Or if somebody's preparing to have that surgery, so sometimes we call it prehabilitation, they might need to prepare themselves, make some lifestyle changes before they have surgery, and that's where motivational interviewing can help with that, or health coaching even. And then in palliative and end of life care, that would also adopt a shared decision making approach, but with the purpose of planning ahead. So if you think about advanced care planning, for example, there might be a treatment escalation plan. So there's a treatment escalation plan called the RESPECT document, which is stands for Recommended Summary Plan for Emergency Care and Treatment. So if somebody is having maybe coming towards the end of their life, or they're receiving palliative care and they want to plan ahead about what matters to them and what their choices are in that phase, then that's what the RESPECT document is around. It's exploring what matters to the person, how and when might they want to be treated. If then plans, if this happens, then yes, I do want hospital treatment, or if this happens, then no, I don't want hospital treatment. So that's what the RESPECT document's around. And there might be a personal health budget that that person might be eligible for. Some of you might have heard of continuing healthcare funding. So that's a pot of money that the individual might be eligible for to help manage their healthcare needs using that personalised care approach. Okay, next slide, please. So, experience, improved choice and control over decisions leads to better experience. But how do we know that? And then I started thinking to myself, going on to my inner ramblings now. This is my inner ramblings. And I thought to myself, often we hear that happy staff equals happy patients. And just over a year ago, there was a personalised care conference by WASP, who I will come on to a bit later. Some of you might have already heard about them already, Wessex Academy for Skills in Personalised Care. They're based in Southampton. It was their conference. And there were a couple of speakers from the Point of Care Foundation, and they were sharing their work with patient experience. And the thing that struck me the most actually is that the patient and healthcare professional relationship is actually a mutually beneficial one. It's almost like a symbiotic. You can't really separate the two. Patients give us much benefit as we give them, and that the patient and staff experience does not occur separately, and in many respects are not mutually exclusive events, but are often measured in that way within the workplace. Next slide, please. So looking at patient experience, so here's an example from the 2023 GP patient survey, which asks about patient involvement in decisions. So it asks, during your last GP practice appointment, were you involved as much as you wanted to be in decisions about your treatment and care? And it got me thinking, what does this really tell us? So just focusing just on the left-hand side of the page, where you can see that little sort of donut pie chart there. 58% of people said yes, definitely. They were definitely involved as much as they wanted to be. 34% said yes, but to some extent, and 8% said no, not at all. And I just sort of wondered really about that 34% where it says yes to some extent. Well, what's the detail on it, and how can this part inform continuous improvement? What can we do about it? And we hear a lot in the media about patient safety inquiries, with those common themes presenting really about patients not being listened to or fully informed or involved in decisions about their care. Next slide, please. And this is the one, Chloe, with the animations bit. So I looked at more national patient surveys. And here are my sort of musings. I call these things musings about that. And many of these surveys are accessible via the NHS digital website. And what was striking for me, or perhaps not so striking, is again, it doesn't really tell us a whole lot. So the questions posed in these surveys can read quite broadly, meaning answers can possibly lack insight into the quality of services that would then inform onward improvements. And it can sort of tell us that there's nothing remarkable to see here, or maybe that not much needs to change. So the common survey questions asked in relation to being involved in decisions ask the patient if they felt involved in decisions, if they are provided with information and support, and if their concerns are listened to. And that the scoring is benchmarked nationally and then measured as about the same, worse, or better. So we can ask ourselves, at what point in the care pathway are the patients asked these questions? And thinking about what constitutes being involved. Does it mean that, okay, well, the patient was present in the room, for example, or does it mean that they were an active participant who has choice and control about their treatment and care? And can we tell how a patient's concerns are listened to? So next animation, please. And some surveys in particular, so actually, for example, the staff survey even and cancer care surveys do ask more specific questions that denote some movement towards action. So has the person got choice and control? Are their concerns acted upon? These were questions. So that action is the thing that actually makes the difference. And if we think about patients' experience with regards to being provided with information and support, and thinking to ourselves, at what point in that process does that happen? So just next two animations, please. And the survey results tended to score lower on average when the patient was asked about the aftercare and the follow-up support of the information provision. Though all of these things, all of these scorings still present under the parameter of things are about the same. So then I thought, with patient safety in mind, how is that box in the middle there, how is about the same or yes to some extent addressed by providers? And are higher risk decisions adequately reflected in the results or onward actions? And do staff feel prepared and equipped to support? Next animation, please. And therefore, what current support mechanisms are there for staff to translate listening into action? Final two animations, please, Chloe. And this, to me, I would assimilate with the with ergonomics. Hence, here the ergonomics of listening. So you might be more familiar with the term human factors. So the two terms are used interchangeably. And this is a scientific discipline concerned with understanding interactions amongst humans and elements of systems and processes. And it applies that theory and principles and data to optimize human well-being and behaviors, as well as overall system performance. This science also accepts that we are human and that we are fallible and we don't always get it right. So therefore, how can we endeavour to improve our processes, our methods, our skills and our style so we can work to get it better? Shared decision making is both a professional and a clinical process. So I just invite you to think about how your colleagues and your teams and your leaders interact with your processes and environment when preparing and carrying out shared decision making or personalised care conversations. Which processes enable this and which processes inhibit it? Next slide, please. So I've tweaked this. This is available on the NHS England website as a shared decision making summary guide. So this would be an example of actually how we can look at our processes of what we need to consider when incorporating a shared decision making approach. How are we preparing our public to engage with those conversations and be active participants? How are we adapting our processes to enable us to enable the patient and work with the patient? And thinking about how these approaches are informing our services and how those services are commissioned. So we think about measuring patient outcomes, for example. Shared decision making is embedded in newer frameworks such as patient safety frameworks. And how we're supporting and providing local education to staff and our teams to better incorporate personalised care skills and techniques within our practice and within the workplace. Now, before we go on to the next slide, I just want to give some examples, because yes, there's already so much more to do, but there's so much that's already been done and already been achieved. So some examples would include Royal Berkshire patient experience teams. So they've been working recently to incorporate personalised care approaches, most notably shared decision-making approaches, within their policies and within their processes. They're working closely with their patient experience leads and representatives to do that. Oxford University hospitals have set up a shared decision-making council, and some services are making a shift towards actually looking at their service outcomes and looking at patient outcomes as measurable outcomes for their services. And just recently, I've seen that the University of Southampton have recently been commended also on their inpatient survey, and coming back to what sort of questions are we asking in patient surveys. So they've really looked at when those questions are being asked along the patient's care journey, and asking patients if they feel that their questions are being answered. That's really important when we're personalising care and services, to really listen to those patients' questions that they have and being able to answer it. So that's really a personalised care approach. In Bucks Healthcare, the children and young persons therapy teams have been improving their services, utilising the digital curation of patient stories to inform their service development. And also I noticed just on Twitter, just before I logged on today, I can see there was somebody called Carl earlier on in the session who unfortunately I missed, looked at incorporating the patient voice into research as well. And we have local maternity systems and transformation teams locally in Bob. They have co-produced a personalised care and support plan with a diverse representation of patient groups in the local area. And that's currently undergoing its first phase of evaluation. Next slide, please. We did a bespoke programme of personalised care training with this team. So the team lead being Sharon Masiwa. So she works in the physical health team for severe mental illness in Oxford Health. And she presented at one of our recent personalised care huddles. And she said, asking a patient what's important to you is the most pertinent question you can ask a patient to personalise their healthcare. And she says that her approach to completing annual physical health checks for patients has significantly changed since she started to implement the personalised care approach in her reviews. She said that her service offers a 1 hour long consultations. However, she's noticed that that time has reduced since she's incorporating a more tailored and personalised care approach in her conversations, which she says she now has more time, more free time to really build that rapport, build therapeutic relationships with her patients, which she wasn't actually able to do before. And these are just a few examples. There's so much work. Just find out, linking with your patient experience leads, find out, if you haven't done so already, what's going on in your own areas. You'll have your own local patient experience surveys. Have a look, have a think, get involved in social care in the voluntary and charity sector. They do a lot of work. Health Watch, they socialise all of their work that they do to represent the patient voice as well. So do find out what's happening in your areas. Next slide, please. If you want to find out more about personalised care or you want to undertake some e-learning, there's some e-learning available. You can register for free at the Personalised Care Institute. There are training providers also registered there, so you can have a look and see what's available. Next slide. And some of those things include some of these training providers, so us in the Bob ICB, so we're just looking at a couple of dates for October and November. In the south of England, you've got the Wessex Academy for Skills in Personalised Care as well. And nationally, there's the Advancing Quality Alliance. Those two provide training, but they adopt a quality improvement approach. So they support teams undertake those quality improvement programs in their area. And the Year of Care Partnerships, they're based in the northeast of England, but they can provide train the trainer programs. But if you visit their website, you'll be able to view the work that they have been doing. They've been sort of instrumental in the development of personalised care and support planning work nationally as well. So I just wanted to mention these organisations in particular because they're the ones that have supported us and influenced things that we have been doing as well. Final slide, please. So I just wanted to finish with this quote here: "A wise person doesn't give the right answers; they pose the right questions." And if you wanted to get involved, there's some social media X. I need to get used to saying X, not Twitter, handles there. And then there's our email addresses there. And thank you for listening to me today.
Thank you very much, Nikki. That was really great. Thank you.
You're welcome. You're most welcome. And if you have any questions, I don't know if there's any questions in the chat or anything, but if you have any questions, I can sort of read them or pick them up a bit later. But thank you very much for having me today.
Thank you. There isn't any at the moment, but obviously if you're hanging around, then keep an eye out. But someone did have their hand up, but it's just gone back down. So I wonder if that was a mistake. But yeah, thank you so much.
Thank you. Thanks.
Oh, someone's hand has popped up quickly. Yes. Oh, two people have got their hand up.
Yeah. Hello.
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 I did ask a question a while ago. It's about a research one. And because this is something I haven't done and I would like to be involved, but I just want to have a bit idea what kind of research support worker because I got two different backgrounds. I worked for NHS as a support worker for decades, and at the moment I am a clinical I'm a therapy assistant with a stroke unit in Maidstone. So if I want to get involved on research, what type of research I need to look at it, if someone can be guiding me and then who to speak and where to start, things like that.
So I can see that both Sajida and Colin have actually answered your question. Have you had a look at it? Have you had a look at the response?
I haven't seen that. I don't know where to get it.
Yeah, so if you click on the Q&A button at the top and then scroll down and find your question, there's two responses there, but it might be worth contacting Colin or Carl directly.
Okay. All right, I will have a look. Thank you.
Yeah, thank you. Okay, I think the other person has popped their hand down, so we'll move on. Thank you, Nikki. Okay, so next up, we have got Sam Young, who's going to talk about her apprentice journey.
Yeah, hi. Can you hear me okay?
Yeah, we can hear you.
Okay.
Just let me know when you want me to move on with the slides.
Okay, will do. Thanks, Chloe. Yeah, so hi everyone. My name's Sam Young, and I've very recently qualified as an occupational therapist after completing the 4-year OT apprenticeship degree. And I'm going to just talk about the journey of that. So next slide, please. So I started working within the Isle of Wight NHS Trust in 2017 on the stroke and rehab ward at St Mary's Hospital here on the island as an occupational therapy assistant. So before this, I worked as a personal assistant for someone for 9 years, and this is where my knowledge of occupational therapy came from, as the client I worked for required regular support from OTs and physios. So I knew that I wanted a career within occupational therapy, as I found this line of work really interesting and I wanted to learn more. When an opening came up as an OT assistant, I was very interested, and I found it beneficial to spend time on the ward before applying for this, to be sure that it was something that was for me, as I had not worked on a ward before, not worked within the hospital before. I learned so much through my OTA role, and this further motivated me to find out a route for me to complete my OT training. So I moved into working in the community in 2018 as a Band 4 assistant, and as I felt this would broaden my knowledge within rehab, particularly in people's homes. This allowed me to set up group working within the community and expand my knowledge in neuro rehab, which I had a special interest in. Next slide, please. Whilst I was working, I liaised with the education department here at the local trust, and I found out the criteria required for the relevant course. I went back to college to gain GCSE I needed in maths, and I also completed a K101 Introduction to Health and Social Care model through the Open University to receive the UCAS points that I needed. I had heard that they were trying to set up the OT apprenticeship, and I expressed my interest in this with the OT that was organising it. I made sure I spent time with other departments to widen my knowledge in OT in other areas such as mental health, paediatrics, the wheelchair service, as well as gaining knowledge from my OT colleagues and consistently asking for feedback on my own performance. I applied for the apprenticeship in 2020, having to undergo interviews with the trust and the university themselves, and I was accepted. Next slide, please. So I started on the apprenticeship in 2020 with my colleague Aisha Cutts, who unfortunately she was going to join me today for this talk, but she wasn't able to make it. So we both worked really hard to ensure that we were accepted on the course, studying through Bristol University of the West of England, where the lectures were mostly online. So the lecturers would sometimes come down to Southampton or Portsmouth for more practical lessons, and there were a few times that we had to go up to Bristol, but all our expenses were paid for, including travel and hotel to pay for accommodation. So I felt extremely privileged to be on this course, and myself and Aisha were the first from the island to start on the apprenticeship. So the apprenticeship was 4 years long, which was studying alongside working. So we both did 30 hours, so 2 days of uni and 2 days of working. I have 2 small children who had just started school when I started the course, which was a challenge in itself. Having to juggle work, study and home life, chucked in with other life dramas, could make a bit of a challenge at times. But the end goal was worth it, and we received excellent support from the uni and from our work supervisors. The online lectures, which are recorded, make it really easy to be flexible around school drop-off and pickups as well. So the benefits of the apprenticeship, so it fitted in well with my busy family life. Both the trust and university take personal circumstances into consideration and are very supportive. It offers a great balance of lectures and work. You get to stay working for the trust, enabling you to keep your pension, your annual leave and your sickness benefits. Feeling valued as both the staff and a student by the trust and the university, still getting paid monthly as an employee, classed as a full-time student, so you're entitled to council tax reductions and discounts, no student debt at the end, and any travel needs and expenses relating to study off island were covered. So over the 4 years, I had 3 placements overall, being inpatient, community and mental health. All of mine were on the Isle of Wight due to my personal circumstances, but Aisha had one over in Southampton, which she found to be a valuable learning experience. Working full-time during placement was an excellent way to gain experience in other clinical areas, meeting our uni objectives and competencies. The Trust and university made sure that our placements met our circumstances. So I spent time in paediatrics, in acute therapies and mental health ward and in the community. Our cohort were brilliant and gave the opportunity to meet like-minded people through the course. They were a great source of support and encouragement when things were difficult. So writing essays took time to master, but I received support from the lecturers and the online library. I was really scared to do a dissertation and had multiple times when I thought I would fail, but I received a really good grade at the end with the support of my family, colleagues and the uni lecturers. It's such a great achievement when you work hard at something and then you get a decent result at the end. So honestly, if I can do it, anyone can. Next slide, please. So my tips for others would be to spend time with other teams, just getting more, if you've got a specific interest in something, just spending time with other people, if your supervisors will allow that, is really good to get more experience in other areas. Be curious in your areas of interest. So I had an interest in neuro rehab and I asked for more patients like this that I could learn more, as well as completed my own research. Being organised, so I had separate folders for the modules that they covered and making notes to reflect on. Knowing how you work best, so I couldn't leave things to the last minute as I would just be stressed, but others worked better in this way to push them to finish an essay. And also used my OT colleagues a lot to help proofread essays and dissertations, which I was really grateful for. Next slide, please. So qualifying as an occupational therapist. So I've been employed as an OT now since July on the rotational post here at St Mary's Hospital. So my first rotation is with the acute OT team, which I completed my second placement with them. So that helped to sort of slot me into place. I have a lot to learn and I need to build my confidence with working on the wards still, but and I continue to work on my continued professional development, which is required to uphold my registration. But a great opportunity for more opportunities and further learning. I'm also due to attend the OT show at the NEC in Birmingham in November, and I'm looking forward to that. So now, when I received my registration, it was such a great feeling. And now wearing my OT stripes, I can be proud to call myself an occupational therapist. Thank you very much.
Thank you, Sam. That was really good to hear your journey, and thank you for sharing your journey with us.
That's okay.
So if you wouldn't mind just keeping an eye out. I do have a question, but I'll pop it in the chat. Oh, someone's got their hand up. Serena?
Hello, sorry, I just have a couple of questions.
Yeah.
You might have even said it and I've just sort of missed it. I have a particular interest in this. This is exactly what I'd like to do within my own trust. They're struggling to set up an apprenticeship, but I live in hope.
Yeah.
But I have a particular interest in the logistics of it, just with you having a young family. And you mentioned that you did 30 hours a week. Was that how it was offered, or was that something you came to an agreement with to allow you to sort of have that work-life balance?
So I already worked 30 hours as an assistant. So being accepted onto the apprenticeship, I was allowed to keep those hours. But most of the people in our cohort did work full time. But so we would study for the 2 days and then you'd either work for 2 for myself or 3 days, depending on your working hours. So it was a nice kind of balance, really. For me, it just worked really well doing the 30 hours and still having that day to life admin and everything. So I also, to be honest, would use that day for essays and things like that to kind of catch up on things, because in the evenings it was just sort of chaotic with the children. So I found it good to have that day, but it depends. If you're working full time already, I'm not sure, you'd have to sort of negotiate that.
I'm part-time,
Okay.
and I was, when we've sort of spoken about it, when I've spoken about it before with my manager, it was suggested that it would be a completely new role that I would then be interviewing for, and that new role would be a full-time role. So I was just interested to hear that it could be an option for it to be not a full-time role, but I guess that would be up to them to then.
Yeah, I suppose if every trust is different. I mean, we were the first ones that were sort of accepted. We were kind of like guinea pigs, really. So they kind of kept us the same hours that we were. But I think the people that are starting on the new apprenticeships now, they are full-time. So it just really dependent on their personal circumstances. I mean, it might be something like you say, it could be negotiated with if you if you get that far to get the post, then I'm sure you can have those discussions.
Okay, thank you.
That's all right.
There's a few more hands up, Sam, if that's all right.
Yeah, sure.
Thomas Wadeson.
Yeah.
Okay.
My question, I'm not sure if you'll be able to answer it, but do you know if you've already got a degree or done a degree, are you able to go on a apprenticeship still?
So I mean, I didn't have a degree beforehand. I had a diploma, so I was again that sort of helped towards my points and things. I do know that there's somebody at the moment. He's not on an apprenticeship, but you are able to sort of do an OT degree after you've done another degree. But I think he's doing that kind of full time. But I'm not sure about the apprenticeship. But I don't see why not.
Yeah, because I was gonna potentially do the masters of
Yeah.
physio, but I was seeing if with the apprenticeship, because that would be a really good option if it is.
Yeah, if you've got like an education department, that's how I sort of found out about it. I went to our education department in our library here and just asked what I would need to be able to get on that. And if they've already got an apprenticeship running with your trust, then it's worthwhile just asking them. Because if you've already got that, then you should be able to still do it, we thought.
Yeah, thank you.
All right.
We've got a few more hands up. If we just do these three, and then you might have to pop them in the Q&A for Sam to type the answer. Is it Rujeko?
Yeah, sorry, that's fine. Yeah, no, I was just going to answer Tom's question. You can, so if you've got a specific degree, there are some degrees that you can actually do like a transfer, and you can do the masters instead. If the degree that you have, it can't be transferred to do like a top up to do it as a master's, you can do another apprenticeship. There is no rule to say that you can't, so you can do as many apprenticeships as you want. One of the ladies that I work with in learning and development, she's actually doing a third one.
Say thank you.
Yeah. Just because, she's been in the trust for so long and she's kind of developed in a role. So do like I said, speak to your learning and development team, or if you've got an apprenticeships team specifically, you should have. They will be able to cross-check what you've got and whether or not you can do the transfer, or if there are specific things, because for some people they're being asked to do like bridging the gap or other things to make sure that they can get onto the next step. Plus, also it depends on how long ago that you did your degree as well, because there are sort of some time limits with that as well.
Thank you.
Right.
Thank you.
I hope that's helpful.
Thank you. There are quite a few responses in the Q&A as well, Thomas, in response to your question. So I'm sorry, it doesn't say your name, it just says meeting guest. You've got your hand up, so I'm sorry, I don't know what your name is.
I don't know if I have my hand up, but my question is, because in my trust we have apprenticeship course, but even if you have a degree, they still want you to have a English and then math level 2, as long as that is not highlighted in your qualifications. So you have to have that. If you don't have that certificate among your different qualification certificate. I don't know.
Yeah, you still have to have, that's the criteria that you have to meet. You have to have the English and maths, and you have to have certain points as well, UCAS points. So that's why it's best just to go and see your learning and development lead, to go and ask them and show them what you've got already and see what else you need.
We'll move on. I'm not sure who it was who's got their hand up, but if you are listening, please put your question in the Q&A. But yeah, Sam, if you could have a little look, there's a few comments, questions for you.
Okay.
Thank you so much. So now we are going to invite Andy back to the floor. So he hasn't got slides, but I think he's going to just have a chat about his journey, his career journey, and then offer an opportunity for Q&A. So Andy, over to you again. Thank you.
Thank you very much. How much time have I got? Because I know we're overrunning a little bit, so I can tailor it to how much time we've got, Chloe.
It's entirely up to you. I think our last speaker...
Very dangerous thing to say, entirely up to you.
To be honest, I haven't got the agenda open, so I've got no idea. Maybe if we give you until like 20 to 1, would that be all right?
Yeah, that's absolutely fine.
Yeah.
I can tailor it to that. So yes, good afternoon, everyone. For those who don't know who weren't in this, who unfortunately got stuck in the breakout room with me, my name's Andy Sharman. I'm currently work for NHS England, and I'm the AHP Senior Workforce and Education Specialist. So I'm just going to tell you a little bit about my career journey. The reason I haven't put slides up is that I know there have been a lot of slides, and sometimes people get slides overload. So this is just going to be a conversation between me and sort of you, and to try to give you a little bit of PowerPoint relief as well. So a little bit about me. I sort of grew up in Midlands. I went to school. I did my GCSEs. Did reasonably okay in my GCSEs. Wasn't spectacular, wasn't the highest performing student by any stretch of the imagination. Probably could have done better than I did, but hey, most of us are in that situation. But I got enough GCSEs to go on and do a couple of do A levels. I did A levels in geography and geology, which I'm sure you imagine are completely appropriate for a career in the NHS. And because my initial career aspiration was I wanted to become a countryside ranger. And I wanted to work because I love being with people. I also love the colour green, which is also really, really sort of nice. And I love wildlife and I love photography. So I did my A levels. Again, realised I wasn't really that good at sort of study along those lines. It made me realise doing my A levels that I am a very practical person, and I sort of need sort of practical stuff. So as a result, my A levels weren't particularly spectacular. I got an E and I got an N. I didn't even know what N was, but apparently an N is a near miss. So I didn't even get enough marks to get an E for my A level in my geography, which was a little bit sort of upsetting, but it did mean I could still go on to the college where I trained, because it was a college of further education. And I spent 3 years doing a national diploma in rural studies. So in countryside recreation, and worked as a countryside ranger for a couple of years. Absolutely loved it. Unfortunately, funding dried up. There was very few jobs around. So I thought, well, actually, I love people. Is there anything else I can do that would involve being with people? And I was like, actually, I saw an advert in my local newspaper to join what was then Surrey Ambulance Service as an ambulance care assistant on the patient transport service. And I was sort of like, actually, I reckon that I could do that. That looks like it could be a really, really sort of interesting job. So I applied and sort of had my interview, and then got offered a job as an ambulance care assistant. So basically, this was before Agenda for Change, but it would have been the equivalent of probably a band 3 role. And the main role and purpose of that role was driving to and from the hospital, taking people to and from their day hospital appointments. Absolutely loved it. Really, really enjoyed it. It was great being with people. It was great hearing the stories, and just loved sort of being out and about and meeting different people. because I joined the ambulance service, there was a really good career progression pathway in there, because this was before paramedics needed to have degrees, and there was a lot of, and it was before apprenticeships formally existed as well. But I look at my career over the past 25 years, which I can't believe I joined the NHS in 1999, and I look at that career and I actually did an apprenticeship without realizing I was doing an apprenticeship, to be honest, because I joined as an ambulance care assistant, did that for a year. That was a requirement. Then you could apply to do an ambulance technician course, which is now what's known as associate ambulance practitioner. That was in-house training in the ambulance service. And then you worked as a trainee ambulance technician for a year. And then you qualified as a technician, and then you could work as a technician. And I worked as an ambulance technician for a further 4 years. Before then, I applied for my paramedic training. Well, actually, for 3 years before I applied for my paramedic training. I was successful in my first application for paramedic training. I applied. Unfortunately, I didn't do that. I struggled because I didn't feel fully prepared for that in-house, because back then, become a paramedic was a 6-week intensive in-house training course with 2 weeks of driving, and that was it. That's what we had. And I didn't do, I struggled, so I actually had to sort of drop out. Did sort of take a little, did sort of hit, so I was a bit upset about it, but it was like, actually there was stuff going on in our family time, in our family as well. And it was like, actually, on reflection, this isn't probably the best time. So I waited until the following year and then reapplied to do the paramedic course then, and had a better understanding of what that would involve. So did my in-house paramedic course, and then passed that time and qualified as a paramedic in 2006. And actually then became sort of registered with the as it was then the HPC, before it became the HPCC in 2006. Again, really, really loved that. And the best thing about being a paramedic, I got to wear green again, because I had green as a countryside ranger, and I was wearing green again. So I don't know what that says about me. I'm wearing blue today, so I'm not sure what that says about me, but hey, there we are. But really enjoyed working as a paramedic, really enjoyed the patient contact, really enjoyed the skills, sort of increasing my skills to allow me to do more for my patients, because my overall focus the whole time was, when I came into this, when I decided to join the NHS, and it sounds really cheesy, I know, but I came into this role because I wanted to have a positive effect on people's lives. And that was the sole reason for why I joined the NHS. And, you know, and going through that career progress up to paramedic was fantastic. You know, it was great to be able to increase that skill, do more for patients. However, then some more evolution happened within my profession, with the paramedic profession, and we had the development of specialist practice within paramedics. And again, within the ambulance service I worked for, I was given the opportunity to be one of the first big cohorts of paramedics to go through specialist paramedic training. And I started that in 2008. And specialist paramedic training sounded a great idea. I really liked the idea of doing specialist paramedic training. But the one problem I had, it meant I had to go to university the first time in my life at 35 years of age, while also having a young family. And to be honest, that was quite a eye-opening experience, because I got this thing saying I was in cohort 1. And I remember my first, I said, sorry, what does cohort 1 mean? And they're going, well, that's group. As if like, duh. It was like, well, I'm new to this world of academia. I'm not an academic. And I've suddenly realized there's this whole new language now that I've got to learn. So yeah, that was where I was when I started that career. I was like, I didn't even know what a cohort was. That was a 2-year program. So I ended up moving off the ambulances and moving onto the fast response cars to do that training. And that was a 2-year program, and it was an undergraduate diploma in healthcare practice. So that was my first academic qualification. Interestingly, all of us would have liked to have done it as a BSc, but I can say this because I am one of these. But the university saw us all as being a bit thick paramedics, and we were whole new, and they weren't sure if we were going to be able to cope with this sort of stuff, because none of us had ever been to university. So we sort of got to do this at level 5, and after sort of passing my first 3 modules with distinctions, I went and said, any chance I can do the rest of these at level 6, and unfortunately I was told I couldn't, because I'd have to go back and do the whole course, which was disappointing. But hey, we were new. It was a whole new concept. It was a risk to the university, because we had these paramedics who just used to fly around on ambulances and take people to hospital. But we were actually sort of doing a lot more for our patients. So again, qualified as that specialist paramedic, and then just really started embracing and loving my role as a specialist paramedic. I spent a lot of time working in primary care, sort of even before paramedics started working in primary care. We were out there sort of working in and alongside sort of primary care. But at that point in 2010, I also became actively involved in my professional body. As soon as I qualified as a paramedic, I joined my professional body, because to me, I've joined a profession, therefore I should be supporting my professional body. So I joined my professional body. But then in 2010, I was going, actually, I'd like to get a bit more involved in my professional body. Is there anything I can do? Because I'd really like to help develop and push my own profession. So I sort of made contact with the college, and they said, oh yes, we're looking for council members. So I was like, oh, well, how do I become a council member? It's like, well, actually, you have to get nominations from 2 colleagues who are members of the College of Paramedics to say that they feel you'll be able to represent their views. And so that's what I did. And I became a council member on the College of Paramedics. And that was, again, a great opportunity to really broaden and widen my perspectives. And I got exposed to a lot, because after working as the sort of council member, one of the things I said, well, a lot of people don't know about the college, so can we set up some regional groups? And I piloted the Southeast regional group of the College of Paramedics, and sort of chaired that group, where we ran local CPD and those sort of things. And that was really, really beneficial, for people to see a benefit from that. And then shortly after that, I was approached by the college saying, our director of membership services is standing down. Would you be prepared to step into that role? And I was like, me? I'm only a paramedic, only a specialist paramedic, and I'll come back to those 2 words a little bit later. Only a. And they were like, I was like, oh, well, yes. And that then got me actively involved in a lot more strategic level, and it exposed me to street. I was attending meetings in London representing the college. The people who may remember the Urgent Emergency Care Review, I actually was part of the committee who sat on that. And I went along, we had these meetings, and they're developing this new policy. And I remember sitting in those rooms and going, okay, so what's happening? And they said, well, we're having a discussion about how we can change things. So have you got any ideas? And I'm going, yeah, I've got an idea. Could we do this and that? And they're going, yeah, okay, that sounds good. We can look at doing that. And then 3 weeks later, you get an email saying, following those discussions, this is some of the policy we did develop. And suddenly I was reading through that and going, I've just created strategy. Just by sticking my hand up and going, I think this is an idea. I've now just created national strategy, which is just unbelievable, really. Is that how strategy is created? It's obviously a lot more complicated than that for actually implementation of it, but strategy is created by people sticking up their hands and going, I've got an idea, and we can sort of do that. So when I was working as director of membership for the college, this was all voluntarily in my spare time. All the work I did with the professional body was in addition to my normal shifts, and I was doing sort of 12-hour shifts, working 3 or 4 days a week, sort of with those. So it was hard work, but I had my 3 days on, 4 days off. I'd be spending time sort of doing my sort of doing some of my college work as well on those days off. And sort of after a while of sort of working in that leadership, that sort of leadership role within, I was like, actually, I really quite like this leadership thing. I actually really feel I've got something I can do this. So how can I develop those skills further? So back in 2013, the NHS Leadership Academy launched the Mary Seacole programme. And the Mary Seacole programme in 2013 was a postgraduate certificate in healthcare leadership. And it was because it was in partnership with the Open University. So for me, I'd got my level 5. Since completing my level 5, I'd also done a level 6 mentorship module. But for my career progression, they often say postgraduate study is required when you're going up to more sort of senior roles. And I'm going, actually, this could be a way in for me to get that magic couple of words on my CV that I've now got postgraduate study. And I applied for the Mary Seacole programme. Very, very competitive process. And to my shock and awe, I was actually selected. Did prove quite uncomfortable because my senior manager also applied for the same course and wasn't selected, which did cause a little bit of friction and uncomfortableness sort of during that time. But I was like, I just need to grab this opportunity. So I explained during my talk earlier, we have these opportunities arise, and when these opportunities arise, we have to grab them with both hands, because you don't know if that opportunity is going to rise again. So I did. So therefore, I started the Mary Seacole program, and it was a postgraduate certificate in healthcare leadership. And oh my word, it was at level 7, and I'm like, I thought I got academia, but now this is a whole new different ball game. It was really, really hard work. And before I applied, I had a chat with my wife, and I had 2 younger children at the time, and I was like, I'm going to have to cancel to actually do this, because I'm not a natural academic. It takes me hours and hours to write essays. I just can't. I get so frustrated when I meet someone who says, "Oh yeah, knock that out in an hour and a half." What? How can you do that? It would take me hours and hours, if not days or weeks, to write sort of essays. So I had a conversation with my wife and said, "Look, I'm going to have to cancel my life for the next year to do this, because I'm working full time. I wasn't getting really any time released from my employer because I'd applied for it independently. Also, not suggesting that was partly due to a bit of bad grades between my senior manager not getting it, but I wasn't released didn't have any time. So I had to take annual leave for those days, or sort of make up the hours in time off in lieu, which was a challenge. But you look at this and go, actually, a bit of short-term pain for long-term gain is the approach I took to that. So I cancelled my life effectively for a year to work and then focus on sort of delivering this. My 2 boys knew very, very quickly that if Daddy's sitting at the computer, it's best not to go and talk to him. And then I would have my days. Then I would have days where I'm not on the computer, where we would just go out and we would do the normal family stuff that we would always do. But it was a real sort of commitment to do that. So I qualified from the Mary Seacole program. I secured my postgraduate certificate. Had a fantastic sort of like graduation ceremony with that, which was delighted. So that was in 2014. So then I was like, right, I've got this leadership qualification now. And what that program did, the Mary Seacole program, I had so much passion and so much enthusiasm for my profession and for patient care, but it really helped shape how I direct that to make change. Because it's all very well being really, really enthusiastic and absolutely passionate, but how you actually phrase your conversations, how you speak to people, how you actually engage with people. And that really sort of helped me to do that. And as a specialist paramedic working in that sort of primary care setting, we had patient group directives which we can use. I could supply 40 sort of different sort of drugs under patient group directives, but often I was finding that the patient group directive drugs would fail because I'd review a patient's medication, it wouldn't work, you only had one backup, they had an allergy to that, you then had to phone the GP and say, could I have that? And it's like, paramedics really need independent prescribing. And the college had been actively involved in working on independent prescribing, and got to the stage that they actually advertised for a role being seconded to the College of Paramedics as a paramedic prescribing project officer. I applied for that role, again, not really expecting to get shortlisted, but did, and then also got the job. So I ended up working as a paramedic prescribing project officer, having an honorary contract, so seconded to the college, but an honorary contract with NHS England, to actually work on writing the national consultation document for independent prescribing, and actually sort of delivering that. That was about sort of 15 months work. Again, loads of fantastic sort of learning for me, loads of sort of discussion, loads of hard work, and loads of disappointment, because at the end of all that, the Commission on Human Medicines decided paramedics were still unsafe to be prescribing at that point in time. So really, really challenging when that happened. So at that point, it's like, well, we can go back, but there's going to be a break. So what can I do now? And I had a conversation with the college going, well, really, we don't really feel we can keep that secondment going in the interim. So I was like, oh, well, I'll look at going back to clinical practice. However, this job came up just at that sort of right time, which was for the first ever Chief Allied Health Profession Officer's Clinical Fellow in Health Education England. I looked at the job description going, nah, not for me. Looked at the job description going, this looks quite interesting, but I'm probably not going to stand a chance. I won't apply. Looked at the job description going, actually, I really like the sound of this. I think I'm going to throw my hat in the ring and have a go and see what happens. So applied, and again, to my surprise, got shortlisted. And that was one of the hardest interviews I think I've ever had. It was a really, really sort of difficult. It was working alongside Suzanne Rastrick for a year, and I sort of had the interview and got offered the job. I was they phoned to tell me, I was almost running around the train on the way home. So I can't believe I've actually got this job, especially when I didn't even think I stood any chance of getting shortlisted for it. And that gave me some great exposure because we got to be mentored by Suzanne Rastrick, our chief AHP, for a year. I mean, how amazing is that? But also I learned so much from her during that sort of process, going through that. And got to lead some national projects. There's some national project on prosthetics or orthotics, and I'm going, yeah, sorry, Suzanne, but I think you've got the P wrong. I'm a paramedic, not a prosthetist and an orthotist. But no, Andy, I want you to lead the project on the national project on prosthetics and orthotics. Okay, but also got involved in advanced clinical practice as well, and actually writing the framework for that. So again, really sort of interesting to be able to have that career. And again, once you're in that sort of environment, you're going, actually, I'm really enjoying this. And then a job came up as a national workforce planner, because that was a year's secondment, and a job came up as a national workforce planner, and one of the national workforce planning team at HE sort of said to me, Andy, we've got this role coming up, would you like to apply? I'm going, I'm not a workforce planner. And they go, you know the stuff you've been doing with prosthetics and orthotics over the past year? I'm going, yeah, that's workforce planning. Is it? News to me. I didn't realize I was doing workforce planning, but obviously was. So I was interviewed for that job, and then worked as a workforce planner for a year. Never in my wildest nightmares, and it would have been a nightmare, did I think I'd be spending a year staring at spreadsheets. But the interesting thing I found is I actually started to quite enjoy it, because I was taking all my skills as a clinician about instead of looking at a person or an injury and saying what's wrong with this, I'd be looking at a workforce or a system and using that critical thinking and go, actually, how can I sort of change things differently? So yeah, worked for that role for a year. Again, it was a year's contract at that point. That was a fixed term, so I'd actually resigned from the ambulance service at that point. So I decided, actually, I'm feeling brave to sort of do this. And then sort of moved into another role more locally, working in the primary care training hubs as the AHP lead, using all that experience. And then from that role moved into a role as a paramedic workforce program lead, and then now into my current role as a senior AHP workforce and education sort of fellow. So a really sort of, for me, I feel really blessed that I've had such a fantastic career sort of during, and it's all because, I took those opportunities when they were arise. And I think the advice I'd give to people who are starting a career or partway through their career, when you're looking at pursuing, even if you're a leadership career or developing, is you need to be passionate and enthusiastic, but be careful it's not seen as arrogance, because I've been accused of that in the past. You have to be brave, but not blasé. And one of the mantras through my entire career has been a quote from Confucius, which is, true knowledge is to know the extent of one's ignorance. Because if we don't know, if we don't know what we don't know, that's dangerous. Whereas if we do know what we don't know, we then know we can bring people around to help us develop. Because I knew nothing about prosthetics and orthotics, but I led a national piece of work which certainly led to the development of a whole new apprenticeship standard for prosthetists and orthotists. And again, the final little bit of things, I know I'm sort of running out of time here. And I think the key thing is, I remember having a conversation with Suzanne Rastrick, and she said to me, Andy, she says, a lot of people ask me, how did you get to where you got to? What was your career? And she says, my response to them is, that's my career journey. Your career journey is your career journey. So it's important you don't try to copy someone else's. And adding to that, we are all individuals. We are all unique, and we all have unique skills and sort of attributes that we can bring and we all have massive transferable skills. And for me to start as an HCA to move up now to where I'm working now, I look back on that and think, how on earth did that happen? I still find myself going, I don't quite understand how that. And the final point I want to say to you is, I often hear people saying, I'm only a paramedic, I'm only a support worker. None of us are only anything. We are all really, really unique individuals, as I said, and we all have something to give. And what's also really, really important is to remember during a career that quiet people have great ideas too. So that's me about a little bit of a summary of my career journey. Hopefully I haven't overrun too long, but grab those opportunities when they come up. The NHS is a great place to work. I just feel so privileged and blessed to have actually been able to do what I've done over these past 25 years.
Thank you so much, Andy. It's always interesting to hear how people end up in certain roles, isn't it? And hearing about how you're not the most academic as well. Yeah, it's just interesting. I think there were a couple of things in the Q&A. I don't know if you want to have a look, but if anyone wants to pop their hand up if they have any questions, then feel free. If not, we will move on to our final speaker. Okay, so lastly, we have got Rachel Jarrett James, who is going to talk about single-handed care.
Hello.
So, hi, Rachel.
Hi.
I'll hand over to you. If you just let me know when you would like me to move on to the next slide, please.
Okay. How long have I got?
Just carry on as you were.
Okay. All right. Lovely. So, hi, my name's Rachel Jarrett James. I'm the Band 4 Therapy Associate Practitioner working on the Single-Handed Care Project with Hannah Foxley over at Southampton University Hospital Trust. Yeah, next slide, please. Are you able to access that link? I'm sorry, I should have spoken to you about this before. This is oh, fabulous.
Want me to play it, or did you want to say something first?
Yeah, please, if you could just play that for me. Thank you.
Oh, you'll need to allow sound. Maybe I need to stop somewhere.
Can people hear the video? Sorry.
No, we can't.
No sound.
No.
You see it,
Right.
but no sound.
Okay. I mean, I don't think it's dialogue.
It's fine. There's no dialogue. It's absolutely fine. Just, yeah, we'll carry on playing it and just have a look at the images. Thank you for that. So the video that you've just seen, it does have a soundtrack. It's only music, but I do think it adds to the video, but I would recommend that you have a look on YouTube for it. This was commissioned for Brian Dolan's Last 1,000 Days project. So project NHS 360 is his organisation. And this was the video that really gave me the passion for the project that we do with single-handed care. And I just kind of want people to have the fact that a lot of our patients are within their last 1,000 days while I talk about the single-handed care project, but also to recognise that when we first looked at our data, one of the very first things that struck us was that about a third of our patients who we were supporting actually passed away before the 3-month check that we were doing. So a lot of our patients, they're not just in their last 1,000 days, they're in their last 90 days, 100 days. Okay, lovely. Next slide, please. So I wanted to just have a quick look at what single-handed care is, what proportionate care is, and it's got a, we're sort of playing with a variety of names at the moment, because within the single-handed care project, we did start out initially to look at potentially reducing packages of care down from double up packages to single packages. But actually what we've found as we've gone through the project is that we can be instrumental in reducing packages of care potentially down from people who may not be able to go home because they need 4 people to roll, to a point where somebody could go home because they only need 2 people to roll on a bed. So that's the reason that sort of single-handed care / proportionate care, those changes are sort of happening. So I also want to have a look at what the therapy support workers' roles are. So next slide, please. So single-handed care or optimized care, or any other name that you might hear it, proportionate care described as, it's the use of specialist moving and handling skills and equipment, and the introduction of additional risk-assessed equipment alongside individualized care plans to get patients home safely whilst reducing care demand and length of hospital stay. The community care system is oversubscribed. Patients are waiting a long time in hospital, no more so, than we're seeing at the moment. It's very expensive for whoever's funding onward packages of care, whether that's the council or patients themselves or families. Care traditionally is often overprescribed by risk-averse clinicians for the right reasons. They don't want people to be at risk once they go home, but actually packages of care which are not individualized to the person or right-sized can be detrimental, because it can lead to people deconditioning. If you have 2 carers going in doing everything for the person, it's very easy to let those 2 carers do that. So we need to make sure that actually the package of care that we're prescribing is not only right-sized, but also is individualized. Okay. So we knew that the project was going to have lots of benefits, lots of barriers. So I've just put some of these here. The benefits are the smaller the package of care, the more personalised care it tends to be. It can reduce deconditioning, it can reduce waiting times in hospital, and there's a cost benefit for the funder, which initially was kind of the direction that we had to lead from in terms of the project and in terms of getting funding. What we're also finding is that more equipment in place helps to manage fluctuating care needs and can actually avoid a hospital admission for somebody who, for example, may not have traditionally gone home with a hospital bed or a stand aid. Actually, we tend to be setting them up for their worst days, their variable days. So that can actually reduce hospital admissions as well. Some of the barriers that we've found are a lack of understanding by patients, families and carers, especially those people who have had double up packages of care in the community previously. It's very difficult to sort of say to a family whose person has had double up care in the community for a year, well, actually they only need a single carer, because it kind of feels like taking something away. So we've been, very conscious of that. And actually, sometimes those are the patients that we haven't reviewed. We've looked at it from an acute hospital point of view, rather than trying to review all those community-based double-up packages of care, which in the best possible way are self-limiting anyway, because those people are either going to come back into hospital or they're going to eventually pass away. So we also looked historically at the risk-averse culture. So the reason that we send somebody home with 2 carers using, say, stand aids or hospital beds, and historically that is what we've done, because we don't want people to be injured using equipment incorrectly, etc. One of the big barriers was that not all the care providers have the training. So we can absolutely recommend a package of care, but actually when that goes out to brokerage, if the care agency isn't familiar with single-handed care and their policies don't allow the use of stand aids, for example, single-handedly, then you can get a lot of pushback with that. We also discovered there was very much a postcode lottery for equipment. We cover a couple of localities, and very much there's a massive difference in the speed of therapy follow-up, but also the speed of delivery of equipment, and sometimes even the availability of equipment. So that was always going to be a barrier for us. We had in the early days, we had a very robust pathway for one locality, but it was very difficult to form that same pathway for the second locality because of the speed and the situation within that locality. Okay, next, please. Oh, excuse me. So in terms of the project, we are reviewing anybody being referred for a double up package of care. So a package of care where they're needing 2 people twice, 3 times or 4 times a day. It doesn't tend to be any less than that, but obviously if they are needing 2 carers less than that, we will definitely get involved. We're looking at anyone with an existing package of care that's a single who's potentially looking at being increased to 2 carers, with a view to potentially putting equipment in rather than that second carer. We're looking at anyone who's needing assistance of 2 support in hospital, who was previously independent at home and is showing potential for either rehab or just for progression generally. And we review anybody also who's going home, all care in bed, home with a stand aid, home with a hoist, and all fast track patients, because traditionally those 4 groups tended to go home with a double up package of care regardless. Next one, please. We get our referrals from our city enhanced trackers. So we have access to those locality trackers. So as soon as somebody's had an ongoing care referral, their name will come up on there. And it is a matter of trawling through and sort of using the filters to cut the list down to sort of 80 odd patients every month or so, and just double checking that we have managed to pick up everybody who fits those previous criteria. We're also on a lot of the team handovers. So on Teams, we have different handovers with different clinical areas, and we tend to monitor those a bit. And just, if there's anybody who's sort of going from one ward to another and it looks like they've got a double up situation on the ward, then we will possibly pick that person up and certainly add them to the list for data. We get referrals directly from the clinical team. We do try and spend as much time as we possibly can on the wards, because obviously people get to know you a bit more, they get to understand the project, and actually you can impart a lot of information in a very short space of time if you know people and you're visible on the wards. We have all of our band 6 OTs and and all the band 7 OTs and some of the band 7 physios are all trained in single-handed care. They've all done the same course that Hannah and I had done, but they are working on the wards in their substantive roles. And so we liaise quite a lot with those people. And actually, Hannah and I, we're only 2 people. So far, we've reviewed 600 patients in just under a year. I think that was our 11-month report that we'd seen 600 people. And so obviously the 2 of us can't do that sort of independently. So a lot of what we do is liaising with those single-handed care trained colleagues, speaking to them about what they've done, and doing almost a distance assessment, and then going and intervening or supporting in areas where they don't have a single-handed care trained colleague, or that person just wants a little bit of extra support. And we've also recently started getting referrals direct from the discharge hub. So actually when a request for a double up package of care goes into the discharge hub, they redirect that to us and say, is this person known to you? Are they, you know, have you reviewed them? So that's where our referrals come from. In terms of what we do, and certainly in terms of what I've been very lucky in that I have been involved, you know, right from the start of this, doing every part of the project. So we do an initial screen once we get a referral. We look at the medical notes, we look at the nursing notes, we look at the therapy notes. We discuss with the referrer to make sure we've got a full understanding of the person's social history and also what the current equipment is that's in situ. And we can make a pretty good guess as to whether they might be suitable for a single-handed care assessment from that. We then will do a physical assessment of any item of equipment that we feel might be beneficial. The main things we use are stand aids, satin sheets. We use a lot of wedges, positioning equipment, and obviously, you know, we put hospital beds into place as well. So I have been doing that independently with the project lead or with the ward therapist as needed. We do a lot of explaining, demonstration of equipment to family and carers. We do a lot of family liaison to understand what their experience has been, what their caring experience is, what their path, you know, what their sort of, what they see their family's discharge pathway as being, and whether they want to be involved with that, so that we can give people as much support as we possibly can. We look at ordering equipment, organising therapy follow-up, so we'll quite often go and do the onward care referral. There is an opportunity for maintenance and progression, and this is one of the things that when we put the business case in for additional staff, this is one of the big things that we were looking at, because we were finding that we would see and assess somebody and they would and they might well be suitable for single-handed care, but in that period of time when they were waiting for that package of care, they were actually deconditioning because either you know, the ward teams weren't confident using the moving and handling equipment independently, or they were staying in bed, or, you know, any number of reasons. So the opportunities for maintenance and progression for people is so important to us. And you know, when we do get the opportunity, we will quite often see somebody 2 or 3 days in a row while they're waiting for their package of care, so that they don't decondition. And we have actually had a situation, or lots of situations, but one particularly recently, where we managed to progress the person from using a stand aid to using a wheeled Zimmer frame in the period between when we had first assessed them and when they went home. And so we were actually able to cancel the stand aid off the order, because this person had actually made the progress and was going home with wheeled Zimmer frame. So we've got, it's difficult. We're kind of a couple of extra bodies at times as well. You know, we know that our staff are, our teams are short-staffed. And so it's nice just to have that additional ability, if you like, that additional capacity to support those patients, because if we're seeing them, that means our therapy teams don't need to see them as well. We do a lot of documentation in notes. We do moving and handling plans, so that when somebody's going home with assistance of one, the care agencies, the families, everybody knows exactly how that person is being supported with just one person. So we would outline, you know, use of a Mo lift with one person, use of Wendy-lets, you know, using the high-low functions on the bed and things like that. And we also liaise really closely with ward teams to hand over and discuss our ongoing plans, and to make sure that they're engaged with those plans. And sometimes, you know, we'll sort of make the plan and we'll say they're just waiting for a package of care. This is where they're at. Are you able to support as well? Okay. So as I said, what else do I do as a therapy support worker? I've been involved with every single part of the project. We do a lot of data recording and we do a lot of data analysis for project results, reports. We've done a lot of education delivery, and education's one of my passions. We've presented at Brian Dolan's NPJ Paralysis Global Summit last month. I have presented at the AHP Support Worker Forum before, so some of you may have heard quite a bit of this presentation before. And I've done multiple in-service trainings across the therapy teams, supporting students on placements. We're in the process of liaising with senior nurses to talk about how we integrate single-handed care into into a ward environment, into an acute environment, because obviously there are issues with the cost related particularly to Wendy-let sheets. They're single patient use, but of course if you send those off to the laundry, they're never coming back. So that's another sort of challenge. But I've been really supported by the Band 8 project lead. I've never been sort of excluded from any of the meetings or the sort of planning. Yeah, so it's been a really, really amazing experience. This is very much an emerging role within therapy, sort of the role of attacking projects in new innovations, if you like. And we are sort of pushing quite a lot of boundaries, looking at some other opportunities, looking at seeing if we can progress a Band 5 support worker role. It's just been such an amazing opportunity to kind of do something completely different. And my ending up on the single-handed care project team was not hugely planned. It was a last minute application. So I think what our previous gentleman was saying is very, very true. Take those opportunities that you get. Okay, next slide, please. So this is just a little bit of data about our project. This is the first 35 weeks. So the numbers are slightly lower than what I was talking about previously. So this was October to May. We saw 460, well, we reviewed 460 patients for single-handed care between the two of us. So that's how many people were on our list. We deemed about half of them, 232, were appropriate for our single-handed care pathways. And there are a variety of different pathways. So we've got the single-handed care, which is going home with a single carer. We've got pathway 3, which is going home with a double up package of care. We've got a pathway that routes people through rehab. And we've also got a sort of a quick rehab pathway, 1T, which we send somebody home with a double up package of care with a very, very quick assessment in the community to try and drop that package of care down to a 1, because we're very aware that people react and respond and rehab very differently at home. So we do have quite a few patients who we know, especially those with some sort of cognitive diagnosis, we know that the chances are they are going to improve quite quickly in the home environment once they're back somewhere familiar. So within that first 35 weeks, we saved 1,562 bed days. 191 patients were discharged home with just a single carer. 38 patients were discharged home with a 72-hour review to implement single-handed care. So that's that 1T pathway I was talking about, sending somebody home with a double up and getting them reviewed really, really quickly. Those discharged as single-handed care, over 72% remained a single-handed care package or no care at the 6-week post-discharge review. And then that went up to 83% by a 12-week post-discharge review. So what we were finding was that people who went home with a double up package of care tended to stay on a double up package of care, whereas those who went on a single package of care stayed on a single package of care, or indeed improved to the point where they didn't need care anymore. And those numbers just went up. So we do a 30-day check, a 6-week check, and a 12-week check. And yeah, 83% were still on a single-handed care or needing no care by week 12, which blew us away, really. 98% of patients on the single-handed care pathway were discharged third place of care. So this sort of fed into our, patients first, patients choice, home first ethoses of getting somebody home at the end of what might be the last 100 days of their life or the last 1,000 days of their life to the place they want to be. Because I know if I have 100 days left or 1,000 days left, I don't want to spend any of them in hospital. But if I have to be in hospital, I want to be there for as short a period of time as I can. So we use the clinical frailty scale as our as one of our measuring I've forgotten the word outcome measures, and the frailty score for patients seen is 7, which is somebody who's quite severely frail. They're completely dependent for personal care, still stable, and not at risk of dying in the next 6 months. And the median age was 82. So actually we know that the patients we're seeing are of an advanced age. They are of an advanced frailty as well. So that statistic that I gave you first up, which was that about 25% of our patients are passing away before the 3-month check, is not surprising particularly, because our client group is older, but it is, I think, very telling that we just need to be respecting these patients' times. Approximately 30% of the referrals that we get are palliative, and that makes it so important that actually we are getting people home as quickly as we possibly can with sufficient equipment and carers, that they're not going to just bounce back into hospital. The referrals by clinical area, the big section there, as you would expect, is medicine for older people, closely followed by medicine, so medicine for anyone. We've also had referrals from surgery, neuro, T&O, CT, and cancer care. So we're covering, the whole sort of range of hospital wards, really. Yeah, so really big, really big client group. Okay. So we're very aware that we're at the end of our first year of the project. It has been an absolute whirlwind. It has been exciting. It has been busy. It has been absolutely eye-opening and fascinating and rewarding at being able to see just how much of an impact that we're having. But Hannah and I quite frequently sit here and go, oh, we need to do so-and-so, or we could do so-and-so, or we could do this, we could do that. So obviously there is a lot of sort of scope for where the project is now going. The biggest one of those, and certainly the one that's going to take priority once we do have a few extra staff, is the training and education of people. So making sure that there is regional involvement with delivering the training. Hannah and I both sit on the steering group, and we're looking at organising this regional training within trusts in the same region, so that we can kind of share the delivery of that. They have agreed a substantive service. So Hannah and I are actually now permanent in our roles, which is lovely. We were seconded up until last month. And then we've got a band 5 coming in, who's going to be part of the rotation. So we're going to have rotational band 5, which is, to my mind, just an absolute straight 6, absolute stroke of genius, because then you've got somebody who you can turn into almost this specialist in 8 months time, and then we move on and we train the next person, and that person goes to their new clinical area with all of this extra skill. So we're also, as I said, we're in stages of trying to get an unregistered band 5 role approved as well, which will be very exciting, just to look at sort of smashing that glass ceiling that exists for us band 4s out there. So yeah, we'll let you know what happens with that. We are also going to be looking at much more maintenance and progression, reconditioning. We know that people decondition when they are unwell. Sending people home deconditioned can have dramatic effects on how well they recover. So actually using that period of time that they are unfortunately waiting for packages of care, whether those are single or double up packages of care, looking at maintaining the condition that those people have and progressing, to perhaps make things a bit better for them than they would have been. We are presenting at UHS Week. We've just discovered that yesterday, which is lovely. That's a week celebrating the work going on within UHS, and we'll be presenting a poster during that week. More data. Our lives are data at the moment. We're coming up for our 12 months, so our lives are more data than they normally are at the moment. Just getting everything sort of tied up and making sure that we can package up that first year and really have a great understanding of how many lives we've changed, how many bed days we've saved, how many people we've sent home with a single package of care who would historically have gone home with a double up. And then, as I said, working with the nursing matrons to work out how to integrate single-handed care into the acute ward environment, which is just so important. Okay, I think this is just a bit of feedback that we've had. We talk a lot. I love, part of the reason I love this role so much is that we get so much more contact with families, with carers, with the patient themselves. And so this is just some of the feedback that we've had. We had a family, the daughter said, "Thank you so much. We know Mum wouldn't be coming home with us so quickly if not for your help and support." And that was the family of a lady who had a very sudden and very drastic cancer diagnosis and a completely unexpected, out of the blue sort of thing. So that was really nice. We got very involved with them. We do have students, and our last third-year OT student wasn't actually our student. We borrowed her from someone else because she wanted to come and have a bit of experience with single-handed care. She said that time with us was the highlight of her placement, which we thought was lovely. And then from one of our band 6 OTs, "Thank you for all your advice and support with my single-handed care onward care referral. You rock," which was very nice, very, very nice. So, we are getting some fabulous feedback. One of the things that we're doing is working with our quality partners, our patient quality partners, to get a more robust system of feedback set up, because it's very difficult to ring families and go, "Hi, how did we go?" Because they're just going to go, "Yeah, it was great, thanks," and that's very nice, but actually we need some genuine feedback about what we did right, what we did wrong, what we could change, what we could improve, all of those things. To that end, one of the other things that we're doing is looking at case studies. So next slide, please. So we've got we pick out patients who we feel are going to be interesting case studies. We don't just use the good ones. We have got some where people have gone home as a single and then the community teams immediately said, "Oh no, we need to increase them to a double up." We look at all of those things, but what I wanted to show you here today was a gentleman who he's a 90-year-old gentleman, so time is limited. He had an existing live-in carer, and it is quite difficult sometimes to get a top up of that care if they need a double up. So it was really important to us to make sure that if he was going to get that top up of his living carer, it was necessary. He had been admitted with a fall, and he was assessed as needing a stand aid assistance of 1, which was great. That's exactly what we want. But in order for him to go home with assistance of 1, we needed to make sure that the living carer was happy with that. So we brought the living carer in and we showed them how to use the stand aid. We did a couple of sessions with them, making sure they fully understood, you know, how to use the belt, how to use the stand aid safely, how to assess whether actually this wasn't a good time to be transferring somebody with a Mo lift with just 1. And we signed them off as being competent to use that stand aid. Now, interestingly, although historically people tend not to use stand aids assistance of 1, there is no information sheet or policy that we have come across that actually says you need 2 people. So it is largely down to the historical sort of risk averse feeling around that. So because we managed to teach the living carer how to use the stand aid, he was able to go home as a single rather than a double. There was no need for a package of care. We organised by telephone to review him by the community therapy team on discharge, and they agreed to accept. We didn't have to do a normal care referral because he was still in, the patient was still in AMU, and he went home the same day, which, you know, would have been a very, very different picture. Luckily, he was in our fast, you know, in the locality that allows us a quick turnaround of equipment as well, because that had he lived in the other locality, chances are we wouldn't have got him home the same day. But the stars aligned. He lived in the right place, and we were able to get that piece of equipment delivered within 3 hours. So prior to our service, he would most definitely have been new double up care. He already had a live-in carer. They'd have had to have had a double up carer as well. And the follow-up data from him was that he was not readmitted. And when we looked up at in week 6, he was actually mobilising with a wheeled Zimmer frame. So in that very short period of time, he'd managed to regain his condition and was able to, you know, go home back to his normal life. And I think that story would have been very, very different had we not been, you know, had we not been around. So it's working, and it's well, just really rewarding, fabulous fun, and you know, real privilege to have been a part of as a tech. So yeah. And that's all from me.
Brilliant. Thank you very much, Rachel. If you could just keep an eye on, I think the chat is open now, and the Q&A, just in case anything comes through for you specifically. But that does bring us to the end of the conference now. I can see that a few people have dropped off, and we'll have to send them to the link to the feedback form. So before you do go, we do request that you do provide us with some feedback, please. That would be really helpful. I think a poll should have appeared on your screen. And then do we want people to also scan the QR code as well, Sajda?
Yes, please. So poll is just one question. It's just a follow-up question on how valuable you actually found the support worker virtual conference today for your professional development. It's just a quick number rating, if you wouldn't mind just quickly taking part in that, and then the QR code.
Yeah.
Once you complete the evaluation form, we've received that. This will be followed up, and we'll be sending you your certificate for attending the event.
Yeah, if you have got a few of you in one room, if you could obviously do, you know, each scan the QR code just so that we can get as many responses as possible, that would be really great. And then, as I say, the people who have hopped off early, we can always send them the link afterwards. So yeah. Once you've done the feedback, then you are welcome to leave. Thank you very much.
can I, whilst everybody is doing that, can I just say thank you to everyone for joining. This event wouldn't have been possible if you all hadn't participated and engaged in all your questions. A thank you to us, Southeast Leads, for making this happen, and a special thank you for Chloe for chairing this event for us. So thank you. And thank you to our presenters, Carl, Claire, Andy, Katie, Nikki, Sam, Rachel, and I hope you guys have an amazing day. I think someone has a question.
I just have a comment, actually. I just want to thank all 160 odd support workers who joined us today. That was massive, absolutely massive. And I am so impressed at the turnout that we have had. So impressed. So, you know, well done, everyone. And hopefully we can do this again, because it was fabulous.
Thank you, Rachel.
Thanks, Rachel.